why you don't use suck anymore? Why we use
Succinylcholine, I mean, it used to be like the only paralytic we really had besides curare, okay? All right, and so number one is why we used it, because it was all we got. And then but what does succinylcholine sound like? What's the big side effect of succinylcholine?
Fasciations.
No.
Choline. What other drug has something choline? It's not a drug, it's biochemical. Acetylcholine. Okay, all right, so the sucks has the same side effects as given, you know, your body's own intrinsic acetylcholine. Bradycardia, secretions, all right, and that's why you had to give atropine. That's where the whole atropine thing came from, is because everybody assumed that if you're given a paralytic, you have to give atropine, all right? Because succinylcholine directly had those effects. It wasn't just, you know, it wasn't pharyngeal, it wasn't anything. It was because you were giving a drug that directly had those effects. So you had to give atropine before. And the reason it went out of vogue is because we have better drugs now, and there were risks. You can't give it, you know, with trauma patients. You don't want to give it to somebody with increased ICP or globe, you know, if they have a globe injury. You don't want to give it to somebody with hyperkalemia. You don't want to give it to a burn, you know, after the first, I can't remember, 12 or 24 hours, all right? So there were lots of rules, okay, after other agents were found that just dropped sucks out of the ballpark, because, I mean, we have way better drugs now. So that do not have those risks associated with it. And there were several kids, when I was a resident, we used sucks all the time. All right, and then when I did fellowship, they never used sucks, and it's because during that last 6 months, there were several, you know, many case reports of children dying from hyperkalemia, all right, you know, that had been given succinylcholine. So, you know, that's why, I mean, there's better drugs. They don't have the risks associated with that drug anymore, so why use it? What are you going to say?
Well, I was going to ask, was it used Pavulon with sucks, or is it Pavulon with vet?
You mean it's pre?
Yeah.
Okay. Which one? Why do they do that? First of all, right? You will answer your own question if you know the theory of the drugs. Why? But why would you use two paralytics?
Succinylcholine is a short-acting paralytic.
Well, no, it had to do with the...
Why use it at all then? If you're going to use two drugs, why not just use the second
Because Pavulon has a longer onset. It has a longer duration.
You are correct in that. However, the real reason is that sucks is a depolarizing.
Yeah, it had to do with
okay, none of the other drugs are depolarizing. What does that mean? Okay, think about it in your regular body. How does your muscle contract? What happens in your neuromuscular junction? It depolarizes, okay, which gives you a muscle contraction. Okay, so basically when you're giving somebody sucks, you're doing this to them. Okay, I mean seriously, you are making their muscles contract. All right.
Because I know
and
it's a
so that's why people would wake up. That's why you get the hyperkalemia. That's why you know, potentially get all these other problems, and why they wake up sore as crap. I mean, it's like they had one big muscle spasm everywhere. All right, so all the other agents are non-depolarizing, which means it just stops the neurotransmitter from being able to produce a signal, and your muscles aren't contracting. They're just in fact flaccid. Okay, because it blocks the neural.
Because I knew with such, you always gave you get Pavulon on lower dose.
That's why, okay,
yeah.
Because you're, right?
Polarizing with
right, but now we got better drugs, so, you know, you don't have to do that.
Sometimes on transports, I know, I guess, I know that Denise has had a kid like this, where you're hesitant about intubating because of blood pressure dropping and, like I had a kid with SBT and was thinking heart failure and all that. What would be your cocktail for your sedation for that, and like what's a
Okay? I mean, I hate this, all right, because honest to God, it's just like, if you're really good at, let's just say you're using an angiocath, the old-fashioned angiocath, and you can get an IV in 5 seconds every time with an angiocath, and somebody brings you this other stupid doohickey, all right, and it takes you 5, you go through 5 catheters and 5 veins, okay, to get the IV in. Which is the better catheter?
In your mind, it's-
For you, right? I mean, okay. Now, what if I, like them other stupid catheters, and I can pop that sucker in, you know, in one try and hit it almost all the time, and if I use your angiocath, I can't get it. Okay? So to me, you know, obviously I like, you know, I hold certain people more responsible for different knowledge, okay? But, you know, if your Chevy is freaking dependable and you drive it every day, then by golly, you're going to take your Chevy on the trip. If you can get an angiocath in the first try and you're comfortable with it, use the freaking angiocath. All right? If you guys are very comfortable using Versed and fentanyl, all right, then by golly, what drug should you use when you're really worried about the kid? Some drug that you've never used before? Or the ones that you know you can predict what happens at different doses, okay? So if you were a critical care fellow, all right, I would not be telling you this, okay? But for you guys' sake, you're gonna be hard pressed to go wrong using Versed and fentanyl.